Hey, what up all my two doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to be continuing our series of central nervous system with antidepressants. This is a shorter topic than usual, so we're going to be going through it in a jiffy. So bring your notes and your pens out so that we can go ahead with our lecture today. Dr. Kanan Shah has put together a great presentation on how depression, if equated with rain, then antidepressants can be equated with an umbrella. See, antidepressants will not prevent the rain or bring sunshine, but it will mask it. It will let our brain be protected from the ongoing rain, which means as soon as our body has no antidepressants, then the rain returns. So, with this principle in mind, we're going to be dealing with antidepressant today, where we treat sadness or all those pleasure reward system routes that have been turned off in our body. We try and bring them back for a temporary basis as long as antidepressants are in our bodies. So, the table of contents. From here onwards, the 1, 2, and 3 are going to be very common as to our other CNS lectures. So I'm going to rush through these first 3 topics and then we'll dive into the deeper ends of the other topics. However, I will make sure to explain and review these points, which are general CNS overview, neurotransmission that takes place in the CNS, the difference between the mesolimbic and nigrostriatal pathways, and how it links to the neurotransmitter behavior. Then we'll move into the biogenic amine theory that explains depression and the role of serotonin with norepinephrine itself. Then the pharmacology, the drugs, the medications to treat depression, and then we'll move on to the opposite side of the coin, which is mania and bipolar disorder pharmacology. Then a little bit of a discussion on the monoamine oxidase inhibitor concept. There are some concerns with this set of drugs, and exams love them. Whether you're in BDS or DDS, or you're taking AFK exam or INBDE exam for the states, these concepts are extremely important. So get your pens and papers out as usual, guys. Come on over and let's discuss signs and symptoms of depression. We know that there's persistent feeling of sadness, there's loss of interest in activities that normally you had interest in. There's trouble sleeping or you're oversleeping. There's weight gain or weight loss changes. We'll get to know that in detail. Fatigue and lethargy is always there. Difficulty overthinking or cloudiness of judgment. Then there's irritability. There's frustration. And then physical aches and pains. This is one of the more frequent ones, that depression is allowed with pain, which is something that we need to treat as well as depression, and of course, suicidal thoughts. So we know that the nervous system is divided into peripheral nervous system and central nervous system. This one has a lot to do with central nervous system. Peripheral nervous system we've discussed in our PANS lecture, which is either cholinergic or adrenergic systems lectures in the previous videos. So we know that the central nervous system has to do with the brain and the spinal cord. However, it's the balance of various neurotransmitters that elicit responses, unlike in the peripheral nervous system where it's only 2 of them, where it's acetylcholine and norepinephrine, that's it. Movement of the body and behavior of the body are very, very significant features of the CNS. We've talked about the behavior during our Parkinson's video, but this one is about behavioral. So what are some diseases and conditions of CNS that we could discuss? Well, neurodegenerative diseases such as Parkinson's, which has been dealt with, psychosis, bipolar, and mania. We'll talk about bipolar and mania today. Psychosis in the future lectures, convulsions in the future lectures. We've talked about anxiety in the past, in the previous lectures, and today we're also discussing depression. Drug abuse and various dependencies will be coming in the future lectures. So the bolded names right here is what we're going to talk about today. How do you fix these problems? How do you treat these conditions and diseases? It's simple. We need to balance the neurotransmission. There's no way that we can unplug ourselves from the cause of it, but we can balance the neurotransmission to treat the symptoms of these conditions, either by excitation or inhibition of receptors. So the most important method to mastering the CNS pharmacology is to be able to understand basic concepts. Once you are able to do that, we can answer all questions associated with the central nervous system pharmacology. Now, speaking of neurotransmission, we've already talked about this, but we're going to go through this so we understand the rest of the lecture today. Our balance of excitation, or in other words, depolarization, through influx of positive ions is very important when we need to excite our central nervous system. On the contrary, inhibition or hyperpolarization is very important through the influx of negative ions. Now, why did I say that? Well, think of it. The word polar means, for example, negative Celsius, right? Polar, North Pole, South Pole is very cold. Remember it this way, guys, where it's negative charges that lead in action potential. However, a depolarization means positive, opposite of polarization. So positive charges inside the neuron. And hyperpolarization means excessive amounts of negative. Now remember, positive means somebody is extremely charged and they're excited. So excitatory. Hyper means somebody who's got lots of negative and they're suppressed. In other words, inhibited. So that's the concept of excitation and depolarization, inhibition and hyperpolarization. We'll take a look at that in just a second. In today's lecture, we're going to be focusing a lot on norepinephrine and serotonin because they have a lot to do with mood, as well as how depression is caused. And all of this will be taken in the biogenic amine theory. So keep an eye out, guys. Now, neurotransmitters for CNS. In the mesolimbic pathway, we're always going to be dealing with behavioral traits, right? It's basically the function of dopamine transport that allows pleasure, reward, and motivation, like it mentions here. It's behavioral. Therefore, the balance between dopamine, serotonin, and of course norepinephrine is very important. More specifically, psychotics and antipsychotics chapter is where we learn the difference between dopamine and serotonin. But when it comes to depression, we will be looking at serotonin and norepinephrine. So let's get that balance in our minds very clear, guys. Nigrostriatal is just the movement one we saw in Parkinson's Introduction to CNS lecture. So we looked at mesolimbic, right? Well, think of it this way. This is where dopamine, serotonin, and all those neurotransmitters origin in substantia nigra. And then they take their different routes to act accordingly. Well, if the red arrow ends up in mesolimbic pathway, it has to do with feelings. And that's the portion of the brain that demarcates what you feel depending on, do you have high serotonin or do you have low serotonin? And by the way, serotonin, the chemical name 5-HT. We'll be talking about that name a lot in today's lecture. So this is a general synapse. We know there's a presynaptic vesicle and a postsynaptic receptor. This is the beginning, that's the end, and target tissue gets affected. Now, there are some enzymes in the middle, in the synapse, such as monoamine oxidase, which break all of the neurotransmitters, such as dopamine, serotonin, or even norepinephrine. They break it down, and they send it back to the presynaptic vesicle. We need to be able to prevent these so that we can cross over the bridge and allow target tissues to be excited or inhibited depending on what we need them to do. Ions such as sodium, which is positive, potassium, which is positive, chlorine, which is negative, all of these get altered from outside to inside and inside to outside in order to provide an action potential that propagates the release of neurotransmitters into the receptors. So let's take a look at that. Excitation is the ion movement through channels at the presynaptic area when there is a stimulation of an excitatory neuron. It will lead to depolarization, in other words, positive, at the postsynaptic membrane. So depolarization is positively charged. Excitation is stimulated by neurotransmitters such as glutamate and acetylcholine, provided there is a positive sodium influx into the cell through the channels, causing neural excitability. Inhibitory pathways of CNS, it's the exact opposite with the same mechanism. So inhibition is through ion channels, right here, except The only difference is that our goal here in inhibition is hyperpolarization, which means we need a lot of negative inside the cell, right? And that inhibition can be done by GABA receptors being activated by GABA neurotransmitter, which indicates chlorine or chloride ion influx, and potassium, which is a positive, efflux, so outside of the cell. That makes diminished action potentials. So it reduces neuronal excitability. I hope that entire concept is clear because we're going to be using that pathway to discuss these following conditions. The difference between anxiety and depression, of course, they're overlapping, but anxiety is unpleasant state of tension, apprehension, uneasiness, and some sort of a fear, such as height or roller coasters, for example. Symptoms include tachycardia, sweating, palpitations. Basically, it alleviates or activates the sympathetic nervous system. So, in other words, it increases the CNS stimulation. That's what it does. Whereas depression is the inability, not an unpleasant state, it is the incapacity to experience pleasures that once existed. Episodes of sadness, hopelessness, sleep changes, lethargy, and suicidal thoughts go into place. So it means we're shutting down our CNS. Now, again, the whole CNS does not shut down. There are certain neurotransmitters that stop acting. And in depression, that is serotonin. What are psychosis and mania? Okay, so psychosis and mania is basically CNS on drugs. It is extremely bizarre, where there is bipolar disorder, recognition disorders, schizophrenia, psychosis, mania. All of these have very common symptoms such as hallucinations, delusions, excessive anger, and rapid thought speech pattern. Now we're moving towards depression. So we always like to, at the Tooth Factory, we always like to teach in a bottleneck format, in an upside down bottleneck format. What is that? It is basically we start at general concepts where everything is encompassed, then we move in closer to our topic of the day, then we classify very similar topics, like for example, anxiety, psychosis, and so on, and finally enter into our depression itself. So upside down bottleneck, right? Let's start depression with the biogenic theory. It defines depression and it also defines mania. But let's see how. The biogenic amine theory defines depression as the deficiency in monoamines. Now, what are monoamines? They are norepinephrine and serotonin. So basically, when serotonin and norepinephrine are decreased in the CNS, it leads to depression. However, mania is the overproduction of the same. So when serotonin and norepinephrine are increased, it leads to mania. That's the main difference between the two types of conditions of biogenic amine theory. The only problem is it's very linear. Like, think about it. Serotonin, which is 5-HT, and norepinephrine work at like 5 different places in the body. Some may have anticholinergic, antiadrenergic, or of course the mesolimbic pathway, and so on and forth. This is sympathetic nervous system, parasympathetic, somatic, so many, right? Well, the antidepressant medications affect only the neurotransmitters themselves, not the locations or the cause of depression. That means that this theory fails to take into account how the neurotransmitters fall out of balance in treating these conditions, and that leads to adverse effect, right? So we just need serotonin to stop working here. But what about here? It stops working everywhere else. Similarly, norepinephrine, if it stops working here, then it stops working in all the other locations as well. That leads to a big list of adverse effects. Therefore, depression is treated by drugs that have a lot of adverse effects. That's the significance of that statement. Antidepressants pharmacology. The goal is to restore the activity of reduced serotonin and norepinephrine. So our goal is to increase serotonin and norepinephrine. That's the goal for depression. One way to do it is to prevent reuptake. That's perfect. It inhibits. But the other way is to stop its breakdown, right? So think about it, guys. The neurotransmitter, this is presynaptic and this is postsynaptic. On its way, neurotransmitters such as norepinephrine or serotonin moves its way through synapse. Now here, right before the receptors, what happens? There are three things that could happen. One, it can get reuptaken. It can get broken down by the enzymes, or it can go to the receptor as is. Our goal is for it to reach the receptor. So how will we end up doing it? We need to stop the enzyme that breaks it down, and we need to prevent the reuptake of that enzyme. So these two are the mechanisms. So let's take a look at that. I'm going to clear this very messy slide so we can focus on the actual matter. The selective serotonin reuptake inhibitors, it selectively stops the serotonin to be reuptaken into the presynaptic membrane. So this is one of the best classes to treat depression, because serotonin is literally the most significant neurotransmitter when it comes to depression. There's another one called SNRI, which is serotonin norepinephrine reuptake inhibitors. Now this is okay, because to treat depression, we really don't care about norepinephrine. We love serotonin, but norepinephrine can cause side effects if the reuptake is inhibited. Then comes monoamine oxidase inhibitors. This is the enzyme. We're blocking the enzyme that is responsible for breaking down of serotonin or norepinephrine. In other ways, all it means, it increases the concentration of these neurotransmitters. Fair enough? Tricyclic antidepressants, TCAs, are technically these, but just an older class. And one of the drug, amoxapine is the name. We'll take a look at that in the future slides here. It deals with blocking D2 receptors as well. So it's anti-dopamine effects as well. Now that's going to be a problem, right? We don't want anything other than serotonin. Remember that fact, guys. Anything more than this will lead to side effects, like this one, like this one, like this one. However, these atypical antidepressants, they're weak. They're not as strong, and they're very antagonistic. It's not the same function as all of these. We'll take a look at that in a second. Treatment of mania and bipolar. Now, the reason why it's in red here is because it's opposite of depression, right? The treatment of mania and bipolar is to balance mood. Now, it's a very complex condition, so the drugs aren't well understood. However, for dentistry, we just need to know the names. Carbamazepine and valproic acid. These we must have heard, and for example, this drug right here, it treats trigeminal neuralgia. And valproic acid is an anti-epileptic. So it overlaps in its actions. And then there's lithium, right? The most important name that we'll hear when it comes to bipolar. Okay, let's classify them name by name, and we're at the tip of our bottleneck, guys. And over here at the bottom, you'll see one point that is very significant about each of them. SSRIs, selective serotonin reuptake inhibitors, such as citalopram, escitalopram, fluoxetine, paroxetine, sertraline, and fluoxamine. Now you notice that there's prams, right, in the citalopram, and there's zetine. Right? There we go. So that's the acronyms to remember the SSRIs. SNRIs are zetines as they are, however, they're dual because they're serotonin and norepinephrine reuptake. So duloxetine, just one way to remember, guys. And then there's these two of the same family, which is venlafaxine. Venlafaxine and desvenlafaxine. Remember, the way to remember this, we need two of the same because we're trying to remember two neurotransmitters. This just has one. So there's pram and there's zetine. However, in these classifications right here in the SNRIs, there's two. So duloxetine and there's two of the same family members, which is venlafaxine and desvenlafaxine. I'm hoping this will help us remember the names, guys, in the exams. TCAs, these are known as triptylines, or another triptyline, or there's pramines. Let's read the name, guys. There's amitriptyline, there's nortriptyline, and protriptyline. Or there's clomipramine, desipramine, and timipramine. There's amoxapine as well as doxepin. So these drugs are very commonly asked for one reason, is what drug prevents the reuptake of serotonin and norepinephrine and also helps in blocking D2 receptors. So that is amoxapine. We'll take a look at the bottom line in just a second here, guys. Atypical antidepressants. Now, these are not very important to remember in their theory. However, the names are important. See, bupropion sounds very much like buspirone, so we can't mix them up. We'll take a look at that in the future slides as well. And all the other ones are odones, and oxetine, and zapion. Now, do you have to memorize these? Absolutely not. You don't have to memorize any of these. But whenever you hear bupropion, we must think about antidepressant, not anti-anxiety or anxiolytics. So remember that, guys. Bupropion is antidepressant. MAO inhibitors, the notorious kind. These names, the first two names, are very, very important, such as isocarboxazid and phenylazine. There's selengeline as well. Remember, this was used during our Parkinson's lecture. So let's take a look at how they actually act, just so we remember each of these categories. SSRIs, they prevent the reuptake of serotonin only. Great. This is prams and zetines. SNRIs prevent reuptake of two neurotransmitters, serotonin and norepinephrine. So there's duloxetine, or two of the same kind, which is venlafaxine, desvenlafaxine. TCAs are either triptylines or amines, and they prevent reuptake of serotonin and norepinephrine, as well as amoxapine stops dopamine receptors. So it's tricyclic amines. Antidepressants that are atypical are weak, but they're very diverse, either preventing reuptake or antagonizing alpha-2 against norepinephrine. Remember alpha-2 from our adrenergic lecture, guys? It's an anti-adrenergic receptor located at the presynaptic vesicle, which takes up norepinephrine back into the vesicle. Therefore, we either antagonize that alpha-2 or we prevent the reuptake like the rest of these categories. And there's MAO. MAO is basically MAO inhibitors will prevent the oxidizing enzyme, which is responsible for the breakdown of serotonin, norepinephrine, dopamine. Now we're thinking about all three of them. Remember, more the neurotransmitters involved, the more side effects there will be. So if I erase this from this entire slide, we can easily say that side effects on this chart right here travels from the least to the most on this way. So this is just for your notes, guys. Great. Let's take a look at the first category, selective serotonin reuptake inhibitors. The mechanism is that consider SSRIs as the drug of choice for antidepression because they specifically inhibit what causes depression. It's the suppression of serotonin. When serotonin decreases, it causes depression, so we inhibit its reuptake, leading to increase in serotonin in the synapse. This selectivity is great because it prevents adverse effects. No other neurotransmitters involved. If it were a non-selective, like a TCA or MAO inhibitors, there would be lots of side effects because there's concentration increase of other neurotransmitters as well. I hope that concept is clear, guys. SSRIs are less active at blocking muscarinic, adrenergic receptors, unlike the TCAs. Therefore, it is even lesser of a side effect. So no anticholinergic, no adrenergic, no issues at all. So we love SSRIs. Okay, here's a little chart that shows up on what uptake inhibition takes place where. So selective serotonin, norepinephrine, nothing, only serotonin. Selective serotonin, norepinephrine, both actions. And tricyclic antidepressants, more action on norepinephrine, less action on serotonin. So if this is great, like if serotonin is a good thing to be acting on, and there's less action on serotonin, then these group of drugs, the TCAs, are really not that great, right? We want more action here. Perfect. So SSRI's therapeutic actions, it increases serotonin in the synapse, takes 2 weeks to produce initial effects, and 12 weeks or more to produce maximum effect, as shown here. Depression to happiness is 2 to 12 weeks. Therapeutic uses. When should we use SSRIs? We can use them in depression and primary indication, obsessive compulsion disorder, panic disorder, general anxiety disorder, PTSD, or being sad, which is social anxiety disorder, and bulimia nervosa, which only fluoxetine can be used. Now, how do you remember that, and what is bulimia nervosa? Bulimia nervosa is a disease of the brain that makes you want to puke whatever you eat. So you eat everything. However, because you want to reduce your weight, you feel out of shape. You don't feel good about yourself. You start vomiting things out on your own. And that's bulimia nervosa. So fluoxetine deals with that. Okay, SSRIs, pharmacokinetics. The absorption is well absorbed orally, takes 2 to 8 hours to act at its peak. The food increases sertraline absorption. So if you were to use sertraline as your drug of choice for depression in SSRIs, you want to take it with food to increase absorption. The duration of action has a plasma half-life of, apologies here, of 16 to 32 hours. Fluoxetine has even more, which is 50 hours half-life, so very long. The metabolism is done by cytochrome P450, CYP450, the big family we talked about in the previous lecture of anxiety, guys. Please check it out. Very important concept. It goes through hepatic conjugation, so liver impairment would be a terrible idea when it comes to SSRIs. But remember, these are happy drugs, so not such a big problem after all. Fluoxetine produces active metabolites known as norfluoxetine, S-norfluoxetine, which is active for 10 days. That's a long half-life, guys. And fluoxetine and paroxetine are CYP2D6 inhibitors. We'll take a look at that in the next slide, what that means. If the patient is with liver impaired, reduce the dose of SSRIs as we just spoke of. And again, because there's active metabolites, there's going to be redistribution, leading to active metabolites action for up to 10 days. Okay, inhibition of CYP2D6. Now remember, CYP2D6 is a member of CYP450. So any drug that is metabolized by this enzyme will be now affected. How? Let's take a look. Fluoxetine and paroxetine will inhibit the activity of a metabolizing enzyme. That will decrease the metabolism of the drugs and lead to toxicity of the drugs because the drugs will not be eliminated. They cannot be eliminated because the metabolism has slowed down. Now, what drugs are we speaking of? CYP2D6 normally metabolizes the following drugs: TCAs, antipsychotics, antiarrhythmetics, and beta-adrenergics, which means the toxicity of all of these drugs will lead to side effects, specifically for fluoxetine and paroxetine. So imagine if beta-adrenergics, which are sympathomimetic drugs, will increase the activity on the heart, then the toxicity of them will even further increase the activity on the heart, causing a side effect such as tachycardia or increase in blood pressure, and that becomes a side effect. That's the formula we use to understand this entire concept of inhibiting a cytochrome enzyme. Side effects: headache, sweating, anxiety, agitation, nausea, vomiting, QT prolongation only for overdose. Remember, QT prolongation for overdose is because sympathetic nervous system is activated. Diarrhea, weak muscles, insomnia, sleep disturbances, weight gains, drug interactions, because we just saw how the CYP2D6 acts, hyponatremia, and sexual dysfunctions. Now, all of these lists you don't have to memorize. How you could understand all of these is where it acts. For example, insomnia. It acts in sleep changes, sleep disturbances. It makes you awake even more. See, depression makes you sleep a lot. To take the drug that treats depression would lessen your sleep. A side effect would even further lessen your sleep, leading to what is known as insomnia. So it's very important for us to link all of these events in our bodies. Next category, selective serotonin norepinephrine reuptake inhibitor. Mechanism is inhibition of both serotonin norepinephrine reuptake, increase in both in the synapse. It's used in patients who did not respond to the first category of SSRIs. Now, here's a fact. Depression is accompanied by chronic pain. Now, why is that important? Well, norepinephrine and serotonin are modulators of pain pathway as well. How neat is that? If depression is associated with chronic pain, then SNRIs are extremely important, right? Well, SNRIs and TCAs are ideal for this reason, such as a patient who has depression and is also suffering diabetic peripheral neuropathy, post-herpetic neuralgia, or fibromyalgia. In that case, we would love to use the duo family, the duloxetine, desvenlafaxine, and venlafaxine. So here's a diagram that explains how they work. See, here's a presynaptic neuron. The blue here, the blue triangle is depicted by norepinephrine. The green square here is serotonin. They're in the vesicle. Because of influx of ions, the vesicles open and all of these neurotransmitters are released. Now, they either go to the receptor, the postsynaptic receptor, and act like they were meant to be, or they can be reuptaken into the vesicle again. To prevent this right here, we have venlafaxine and duloxetine. Antidepressant blocks the reuptake of this neurotransmitter. Hope that's clear, guys. Next category is atypical antidepressant. Remember the mechanism, it's mixed. They're weak, but they're varied. And bupropion, remember it's not buspyron. So let me put this here for you guys. Bupropion is depression treatment, whereas buspyron is anxiety treatment. So let's remember that. Okay? Bupropion is a weak dopamine and norepinephrine reuptake inhibitor. Therefore, it can only be used for symptoms of depression, not depression itself, because it works on dopamine and norepinephrine. There is no mentioning of serotonin. And remember, according to the biogenic amine theory, depression is dependent on serotonin levels. So bupropion can only treat symptoms. It decreases the cravings of nicotine, by the way, so it can be used in the treatment of smoking. Mirtazapine is antagonistic at presynaptic alpha-2 receptors of serotonin as well. So mirtazapine, really, really good. It's perfect, but it's weak because it acts at a specific receptor rather than hunting down all of the serotonin and preventing it to go up. However, on the other side of the coin, it is potent antihistaminic property, so it causes sedation. So again, same thing as this, treatment of the symptoms. If you cannot sleep because of either, say, depression or anxiety, you want to be sedated and put to sleep, here's your drug. And then comes the odones. Remember the odones? These are atypical antidepressants. They're weak serotonin reuptake inhibitors. They're just weak. So again, symptomatic treatment only. TCAs, tricyclic antidepressants. So we know by this chart here that they affect serotonin, that's great, but they affect norepinephrine more. So what's the significance of that? Let's take a look. They inhibit serotonin and norepinephrine reuptake for both. It's perfect. It blocks serotonergic, alpha-adrenergic, histaminic, muscarinic receptors as well. Now, this statement is literally the most important statement on the slide, guys. I would put this statement in bold red letters. Why? Because it shows us the side effects of TCAs right in front of us. Our goal is to stop serotonin from being diminished, correct? But why is it blocking adrenergic receptor, histaminic, and muscarinic receptors? Now, what do we have? We have anticholinergic and anti-adrenergic effects all over the place. So, for example, amoxapine also blocks dopamine. Now we have anti-dopaminergic effect. It's like it's endless. It's 3 times the cost to treat depression. Technically, in today's time, SNRIs are technically TCAs due to its blocking activity on several receptors. It is far more adverse in side effects. The prototype of TCAs is imipramine. TCAs, therapeutic actions. It elevates the mood. It increases mental alertness and allows physical activity. That sounds really happy. It reduces morbid depression in 50 to 70% of the population. That is also great. What does morbid mean? Something that makes you weak in the body. So a depression that actually changes you psychologically and physiologically is treated by TCAs. It takes two or more weeks to initiate mood elevation. The therapeutic uses is moderate to severe depression, panic disorders, and bedwetting in children 6 and older is now replaced by desmopressin. Now, why is that? So remember when we try and link pharmacology, think of it this way. Bedwetting means increase in bladder action. What does that sound like? To me, it sounds like cholinergic action on smooth muscles. What does TCA block along with serotonin? It blocks cholinergic receptors. What does that mean? That the bladder muscles reverse and they stop working. Hence, it treats bedwetting in older children. But nevertheless, due to other side effects, because it blocks adrenergic receptors as well, it's now replaced by desmopressin. Amitriptyline prevents migraines and neuropathies as well. Doxepin at low doses treats insomnia. Pharmacokinetics, very, very simple, well absorbed orally. It is lipophilic and it crosses blood-brain barriers readily because of it. Metabolism-wise, variable first-pass metabolism leading to low bioavailability. What does that statement mean? Well, think of it this way. Here's a drug, goes through the mouth, touches the liver. The liver sends it to first pass metabolism, goes around the liver, comes back for second pass metabolism, and then out through the urine. Okay, first pass metabolism determines how much gets absorbed into the body and comes back for inactive molecules to be passed through the second pass metabolism. Now, what if this is variable? What if we can't predict the first pass metabolism? How about it's variable? That's when the bioavailability becomes very, very low. It's unpredictable. So it is metabolized by the same family, CYP450, hepatic conjugation, excreted through urines if the metabolites are inactive. Adverse effects. Remember, a huge ton of adverse effects, antimuscarinic, or in other words, anticholinergic. Blurred vision, xerostomia, so decrease in any excretions. Urinary retention, remember the treatment of bedwetting. Sinus tachycardia, constipation, aggravation of glaucoma, and life-threatening arrhythmia. Now that's worsening. Alpha adrenergic blocking, what does what does it take place? It prevents blood pressure from going up. It in fact stops the blood pressure from going up at all. So it can lead to postural or orthostatic hypotension. It leads to reflex tachycardia, thinking, why is my body lowering all the beats per minute? Let me reflex myself out and bring back the increase in heart rate, and dizziness. Histamine, H1 blocker, which is sedation. And other is, of course, weight gain and sexual dysfunction as a part of overall side effects. So that's a lot of side effects, you guys. Here's a drug interaction explanation. Here's tricyclic antidepressants. Okay, let's take a look at the bottom area first. The ethanol or other CNS depressants that are taken with TCAs will lead to toxic sedation. We know the side effect of TCA sedation for sure, right? Because of H1 blockers. But if you took alcohol with it or other depressants with it, in that case, it will lead to toxic sedation. Indirect acting adrenergic drugs. If, for example, indirect acting adrenergic drugs are taken, it blocks the effect of indirect acting sympathomimetic drugs by preventing the drugs from reaching their intracellular site of action. So, for example, if you're taking a alpha 1 agonist, in that case, TCAs, in addition to it, will prevent the activity of adrenergic drugs if it is indirect acting. That's all it's trying to say. It nullifies the action because TCAs have an anti-adrenergic effect, leading to the prevention of agonistic effect. Okay, so that's clear on this end, guys. Now, let's take a look at the top end of it. When tricyclic antidepressants are taken with MAO inhibitors, then there's a mutual enhancement of the same side effects, not opposite, same side effects, such as hypertension, hyperpyrexia, convulsions, and coma, because MAO does the same thing, side effects, same thing, just worse. So imagine taking them together. Direct-acting adrenergic drugs on this end will potentiate the effect of biogenic amine drugs by preventing their removal from synaptic cleft. Now, direct-acting means, for example, that alpha-1 agonist will directly bind to the receptors, and tricyclic antidepressants will prevent adrenergic effects. Now, what happens is because of this nature of TCAs, alpha-1 agonists will be hyperactive and they will bind even stronger, almost irreversibly, leading to potential effects of biogenic amines. That includes norepinephrine in this case. That's where the side effect of reflex tachycardia comes into play, which is here. So, do you need to know all of this depth? No. The reason why we're doing this story is so that tricyclic antidepressants are clear from the core concept for us. Moving on to monoamine oxidase inhibitors, the last family of the day. The mechanism is that it acts as a safety valve. Honestly, MAO inhibitors are made for a good reason. They're actually happy drugs because it deactivates excess norepinephrine, dopamine, and serotonin. But MAO inhibitors then inactivate the enzyme MAO. Therefore, there is an increase in norepinephrine, dopamine, and serotonin concentration in the synapse. So not only excess, but it increases normal concentrations of all three, norepinephrine, dopamine, and serotonin, all at once. These are the big fours. I call them tips. The tips is the cypromine, the carboxazid, and phenylazine, and celangeline, which is anti-Parkinson's. These are tips, so MAO tips. MAO inhibitors also block MAO in gut and liver. That is very, very important to understand in our next few slides. Remember that concept we were talking about at the end of the lecture? This is that concept. When MAO is supposed to block just CNS, but ends up blocking gut and liver, what happens? We'll take a look. It blocks the metabolism of tyramine. It leads to its toxicity. Now, the word tyramine is very, very important. So remember that it has been asked in the exams before. Effects of MAO inhibitors. It prevents the inactivation of monoamines. It causes excess neurotransmitter to diffuse into the synapse. So remember, when it leaves the vesicle, there could be inactive metabolites caused by MAO, but MAO is inhibited, leading to excess of norepinephrine, dopamine, serotonin going to the postsynaptic membrane. The therapeutic actions then is delayed antidepressant effect up to several weeks, amphetamine-like stimulation, and that's hypertonic, like it's really, really high. It's CNS alertness altered to an increased level. So it can cause insomnia, like you're always awake and you're agitated, like you always want to do something and talk something really fast. That's MAO's therapeutic actions. The uses, however, are treating depressions for patients who are allergic to TCAs and SSRIs. That makes these the last line of drugs. The atypical depression is treated by MAO, something that cannot be treated normally. But there's drug-drug and drug-food interactions that are very concerning, making it the last line of drugs. Pharmacokinetics, it's literally the copy of TCA. It's the same mechanism, well absorbed, lipophilic, crosses blood-brain barrier, and variable first-pass metabolism prevents any bioavailability from occurring to that high extent. Metabolism is by CYP450, hepatic conjugation, and excreted through livers if the metabolites remain inactive. Adverse effects. Now we're talking about tyramine. So pay attention, guys. I know it's been a longer and a very boring lecture, but they're very important when it comes to dentistry, guys. So drug-food interaction. This is new. Tyramine is a chemical in foods such as cheese, which is aged, meat, fish, and red wine, which means it's consumed by a lot of our citizens. MAO normally inactivates tyramine. However, MAO inhibitors from the CNS also leaks out and blocks MAO in the gut, causing tyramine toxicity. Tyramine is notorious. It stimulates the release of catecholamines such as epinephrine. So if there's too much of tyramine in the gut and gets absorbed, epinephrine gets released, leading to hypertension, occipital headaches because of throbbing pains in the peripheral vessels, right? This is alpha 1. This is beta 1. Tachycardia, alpha 1 and beta 1. Cardiac arrhythmias, when beta 1 and beta 2 are both activated. Nausea, seizures, stroke maybe. Therefore, patients on MAO inhibitors should be instructed to avoid tyramine-containing food, such as cheese, meat, fish, and red wine. How does that link up, guys, eh? Pretty cool. Phentylamine and prazosin, which is alpha blockers, are used to help treat the symptoms if needed. So, what does that mean? Well, think of it this way. When MAO inhibitors are taken with tyramine-containing food, in that case, using an alpha blocker is very useful, such as phentylamine and prazosin, because it prevents these severe side effects. So hope everything adds up very well, guys. And here's just a chart for all antidepressant side effects that we talked about in overall entity. I've left it empty so that you guys can write a little bit of your notes in the back here to color code your drug groups here as well. So you can feel free to pause here and read the chart as well. Moving on to the last part, the opposite side of the coin, mania and bipolar disorder. See the mechanisms. First of all of us, we need to know. That's the third one. Okay, treatment of mania and bipolar disorder. Now, first of all, let us recall that these are opposite conditions to depression. It is excessive serotonin. This is elevation of serotonin, norepinephrine levels above equilibrium, causing excessive stimulation. The drugs used in the treatment of mania and bipolar disorders are as follows. We have lithium, lamotrigine, carbamazepine, valproic acid, haloperidol, chlorpromazine, and dones and apines. Okay, how do you remember these? Well, lithium is number one. It's unknown action. It's the best choice for anyone who's liver impaired. And if there's somebody with renal impaired, please be very careful because it excretes through kidneys. Unlike other drugs, which are anti-epileptic in nature, carbamazepine, you remember, used in the treatment of trigeminal neuralgia. This is used in tonic-clonic seizures. Lamotrigine is another one used in tonic-clonic as well. Haloperidol, chlorpromazine are old antipsychotics, and risperidone and olazapine are atypical antipsychotics. Again, this is just next lecture, so we'll talk about the psychotics, antipsychotics in the next lecture. However, all of these drugs are mixed action. They're anti-epileptic, antipsychotic, anti-mania, anti-bipolar. These are the drugs that we may have to deal with. Now, lithium, on the other hand, is very important for us in dentistry, especially for exams. Normally, lithium salts are very toxic. We can assume that from the name, right? But therapeutic index of lithium is very low. What does that mean? Well, it means that the ratio of effective dose over lethal dose is very low, which means, if you think about it, let me erase this here. So we can say the effective dose is, for example, 2 milligrams of the lithium salts cures the disease. However, only 1 milligram is lethal enough to kill the subject. What does that mean? That it's only 1 milligram away from killing you from the treatment dose. So the dose required to be effective and kill the patient are very close to one another, especially less than 2. This equals 2 divided by 1. Common side effects because of that are polyuria, polydipsia, polyphagia, fine hand tremors, dizziness, fatigue, sedation, and NSAIDs interaction. NSAID, when taken with lithium, will increase lithium toxicity in the liver because it prevents lithium metabolism. So remember that point. That, I'll write this down again, guys, that NSAIDs prevent lithium metabolism or excretion. And yes, we focus on excretion a lot. Now, why is that? Remember from my NSAIDs lecture, they have a huge impact on kidneys. And because of that, the kidney fails to excrete lithium from the body, leading to backward reaction of toxicity. So NSAID plus lithium means lithium toxicity. Then the high dose side effects kick in, which is ataxia, slurred speech, large tremors, confusion, and convulsions. So basically a heavy version of this list. Awesome. So our lectures are resourced from Lippincott and Litton-Fallis. The links are in the description box below, guys. And thank you for watching. Thank you for staying tuned with us. Apologies for it being boring, but see you in the next lecture for further dental pharmacology. Hope you guys enjoy it. If you have any questions, reach out to us in the comments section below. Thank you very much. Have a great day.